I'm Dr. Bill Gradishar, I'm breast medical oncologist at Northwestern University in Chicago.
Hi there, I'm Dr. Tiffany Traina, breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York.
So, Tiffany, welcome, and I'm glad we're sort of coming to the tail end of San Antonio after a very long 4 days and nights.
That's right.
But I wanted to get your input on a few of the trials, not so much that they were reported at San Antonio, but they've been very recently presented at ESMO. And although they're not yet applicable tomorrow, we anticipate that some of this data is going to be used in the clinic very, very soon. So the two trials that I wanted to get your insights about, starting, of course, with TROPION-02. Can you just sort of explain the trial, the mechanics, and then we'll get into some of the details about it?
Sure, happy to. So TROPION-Breast02 was a first-line trial for patients with metastatic triple-negative breast cancer that were deemed not to be candidates for immunotherapy. So really important sort of first distinction when we're thinking about treatment for patients in that line with TNBC. And that definition could have included PD-L1 negative tumors or perhaps prior exposure to a checkpoint inhibitor, or potentially in an area of the world where access to a checkpoint inhibitor may have been limited. Patients had no limitation on disease-free intervals, so they could have been progressing on their therapy, on their adjuvant therapy, and they were randomized to either Datopotamab Deruxtecan as a single agent or to investigator choice chemotherapy, which was either a taxane like paclitaxel or nab-paclitaxel or single agent carboplatin, capecitabine, or eribulin. The primary endpoint of the study was actually powered for a dual primary endpoint of both progression-free survival and overall survival.
Okay. And you made the comment about the disease-free interval from their last therapy. Why is that important, potentially?
I think that's really important because these are some of the toughest patients that we treat today with really aggressive disease. Oftentimes, these patients are seeing an anthracycline, a taxane, potentially a platinum. Even in the context of KEYNOTE-522, they're seeing checkpoint inhibitor. And so if you're recurring on or even within 6 months of that therapy, this is really refractory disease.
So these are bad-acting tumors.
Exactly.
So tell us, go ahead.
Oh, the other thing I should mention is in this patient population, they allowed for stable treated brain metastases, which is also an unmet need in TNBC.
Great. So tell us a little bit about the high-level results from this trial.
Of course. So first primary endpoint to look at was progression-free survival. And this had a meaningful, clinically relevant difference favoring Dato-DXd over standard of care chemotherapy, numerically about a 5-month difference in median PFS, really powerful, both statistically and clinically meaningful there. That was both by BICR as well as confirmed with investigator-assessed, like consistent data there for progression-free survival. I think really exciting subsequent analysis was the overall survival data, which also was positive. And this is really, I think, practice changing for first-line metastatic triple-negative breast cancer. Numerically, again, about a 5-month improvement in median overall survival, about a 20% improvement based on the hazard ratio, and that met statistical significance.
Great.
And then, I think there's a third very meaningful efficacy endpoint that we saw as well, which was overall response rate. So with Dato-DXd, responses were upwards of 60% compared to standard chemotherapy, which was about 29%.
Right. And, this improvement in outcome, what was it in terms of cost, side effect-wise?
Oh, always an important sort of risk-benefit balance here. So Dato-DXd was incredibly well tolerated. So grade 3 or greater events were really uncommon. Discontinuations due to treatment-emergent adverse events were less than what was seen with chemotherapy. And I think we also want to consider some of the logistics of receiving Dato-DXd. So it's an intravenous infusion once every 3 weeks, and the infusion time and the chair time is actually shorter for our patients. So when we think about how they're spending their time while they're living with metastatic cancer, it's wonderful to keep them out living life as opposed to in the infusion suite.
So we're going to talk about the other trial that got a lot of attention at ESMO. But before we get to that, there are two things that I wanted you to comment on. One is there wasn't a crossover. And number two, what was the subsequent, how many patients got to another line of therapy?
Great point. So the design, as we talked about, did not build in crossover. And I think that's understandable because Dato-DXd was not indicated in triple-negative breast cancer in later lines. But based on standards of care, kind of in the US and elsewhere, having access to an antibody drug conjugate is relevant for later lines, such as Sacituzumab Govitecan, and in parts of the world, Sac-TMT, or even Trastuzumab Deruxtecan if you have HER2-low disease. So what we've seen is for patients who are on the control arm for Dato-DXd, about a third of them went on to subsequent ADC therapy. And I think we look forward to seeing more kind of resolution and details around that.
Yeah, I'm always struck when you look at the data that there's a significant fraction of patients that never get to that second line of therapy.
Absolutely sobering in TNBC, and that really argues for using our best therapies in the first-line setting because many real-world data sets have said anywhere from 40 to 50% of folks never make it to second-line treatment.
Okay, so let's pivot to the other trial, which is ASCENT-03.
Can I derail you for a moment, though?
You can.
Okay. I realize I would like to go back and talk about some adverse events of special interest with Dato-DXd that
Please do.
Yes, thank you. We didn't actually touch on. So I think one key thing to keep in mind, even though this payload deruxtecan is the same as what we see in Trastuzumab Deruxtecan, rates of ILD in this particular trial were incredibly low, less than 1%. So we can't just assume because the payload is the same that the toxicity profile will be the same.
And the follow-up was the same in terms of imaging every couple months looking for ILD?
I believe so.
Yeah.
I believe so. And then the other two adverse events of special interest are stomatitis and ocular surface events, so pretty much dry eye. Both of those reassuringly resolve over time. At the time of the data cutoff, most had resolved their adverse event. Most are low grade and can really be prophylaxed for in the setting of stomatitis or mucositis using oral Dex rinse and cryotherapy. For ocular surface toxicity, there is a requirement in the label to just have a baseline eye exam by either an optometrist or an ophthalmologist. Again, using lubricating drops, avoiding contact lenses, those sorts of things can really mitigate the eye toxicity.
Good, good. So let's come back to ASCENT-03. Tell us a little bit, again, the mechanics of the trial, and then we'll go to the high-level results.
Sure. So ASCENT-03 has many similarities to TROPION-Breast02. It is a first-line trial for patients with metastatic triple-negative breast cancer who were not candidates for a checkpoint inhibitor. The definition there is a little bit different. So patients either needed to have a PD-L1 negative tumor or a contraindication to receiving a checkpoint inhibitor or potentially had previously received it. This trial did have a bit of a cap on disease-free interval. So you needed to have at least 6 months of therapy, 6 months of distance from your early stage therapy before coming on study. And the trial capped those with less than 12-month disease-free interval at 20% of the study population.
So sort of weeding out that bad group.
That really early progressor, exactly. The study randomized patients to Sacituzumab Govitecan as a single agent or standard of care chemotherapy. Here the choices are a little bit different, taxane again, or the combination of gemcitabine with carboplatin. Other significant difference is the trial built in crossover. So if you were on the control arm and had progression of disease, you were offered, enabled, provided sacituzumab in that crossover. And the primary endpoint is powered exclusively for progression-free survival. Overall survival is a secondary endpoint.
Okay. And you know, one of the things coming back to TROPION-02 is the chemotherapy choices. So between the two trials, obviously gem-carbo was one thing, or you got a combo option in ASCENT, not in TROPION, and capecitabine is in one versus the other. Do you think those chemotherapy choices may have driven any of the outcomes, which we'll come to in a minute?
I think it's a great question. You know, I don't think we've seen that the combination of gem-carbo is going to impact overall survival. So it may explain some differences we might see in how the control arm performs in terms of response rates in these trials. But I think there's some confounding here because that disease-free interval matters. And we need to think about what those patients saw in the early stage setting, and that would drive what they then were getting as the investigator choice on the control arm if they were a rapid progressor, for example. So even in TROPION-Breast02, the vast majority of patients were getting a taxane. Almost 80% of folks saw a taxane as the control arm therapy. In ASCENT-03, it was a bit more of a sort of 40-60 split between taxane or the gem-carbo combination. So I don't know if that is explaining some of the differences that we see.
Might have
in the
explained response rate,
Exactly.
perhaps. So tell us a little bit about the high-level results again from the ASCENT trial.
Yeah, so a great positive trial, wonderful to see for our patients that, again, progression-free survival is the primary endpoint, and that did favor sacituzumab over standard of care chemotherapy. Numerically, obviously, the difference is a little bit smaller. The median PFS with sacituzumab was about 9 months and change. The control arm did a bit better than what was seen in TROPION-Breast02 at about 6 months and change. And so a significant, both clinically significant and statistically significant difference was seen there.
So do you think weeding out, as they did in this trial, patients who didn't have rapid progression may have explained the smaller delta?
Perhaps. I mean, I think it might explain why we have just a better performance in the control arm, if you will, and then there's just that slightly less performance in the SASI arm.
All right, so we have these two data sets, one clearly showing a survival benefit, both showing improvement in PFS.
Yeah.
Both drugs are out there, although I think probably people are increasing their experience with Dato more than they are with SASI, which has been around for quite some time. So how do you guide, your referrals that come in about what the best choice is, or even talking to patients?
Yeah, so I think as we talked about in TROPION-Breast02, it's relevant to talk about what toxicity looks like for ASCENT-03 and for sacituzumab. And clinicians out there have a lot of experience with sacituzumab, given its indications already in later line TNBC and hormone receptor positive disease. But what we're really seeing with sacituzumab is primarily about 8% or so grade 3 diarrhea. We know even grade 2 diarrhea is clinically significant. So we need to keep that in mind as we're thinking about patient selection. And then neutropenia and cytopenia is a real concern. So in this trial, growth factor was not mandated, and there were some deaths on study, and those deaths were largely related to infection and neutropenia in patients who didn't really get growth factor support. So I do think we need to be sensitive to thinking about that sort of prophylaxis and protecting our patients.
So do you do that now? Forget the study, would you?
Right, so typically, and this is actually baked into recommendations now, that with sacituzumab, I tend to use a long-acting growth factor on my day 8 to just help support my patient through their next cycle.
Exactly what we do.
Yeah.
So again, there are differences between these trials, including the schedule. So it sort of becomes individualized based on what a patient may be able to do or want. So how do you think about that?
I think that these are really shared decisions and decision-making that we have with our patients. We have differences in toxicity. We have differences in logistics that are not trivial. It's a challenge, especially when patients are coming from a great distance to see their clinician or get to an infusion suite. 3 hours or 2 hours in an infusion chair is time away from doing something else.
Right.
So I think these are discussions that we have. The overall survival data is just really compelling and nice to see in the TROPION-Breast02 study. I think we have to give kudos to Gilead and the sponsors for ASCENT-03 to be able to offer and enable crossover so that patients are getting access to that post-ADC therapy. So I think the absence of seeing an overall survival difference there, it is perhaps a function of just the design of that trial, and that makes it a little bit difficult to compare. And we have to keep in mind these patient populations are so different too.
Yeah, I mean, we have this same conversation about the new endocrine agents and whether, you can compare. You're never supposed to put them side by side, and then we do it on a slide.
That's
so
right.
I think we always have to emphasize that, the composition of the trials was a little bit different. There are differences, subtle, but true differences.
With the TROPION-Breast02 trial, we saw almost 10% of patients having stable treated brain mets. So that's really enriched for, a difficult to treat patient population. We also saw in terms of PD-L1 status, TROPION-Breast02 had about 10% or so of patients that actually had PD-L1 positive tumors. And yet both of these trials are happening at a time when we weren't really seeing folks progressing off of Keynote 522 and coming on to these trials. So only about 5% of folks had seen prior checkpoint inhibitor. So this is the space that we're in these days, which is so rewarding that we've got new drugs coming. It feels like there's new data to catch up on every couple of weeks these days.
Yeah.
But the current standards of care are moving so quickly that we need to just extrapolate and make some assumptions because we don't have the big randomized trials to guide us in that regard.
So let me ask you one other question, which isn't a function of either study. So whether you're on SASI or you're on Dato and you progress, what would you do?
Are you going to ask me the sequencing question?
Well, of course, you have to ask it for which there's no right answer.
That's right, exactly.
So you can say that.
Right. I'm totally teasing. So absolutely right. This is a challenge that we have. We now have multiple antibody drug conjugates, which is fantastic for our patients, yet their payloads all have a similar mechanism of action. They're all topo-1 isomerase inhibitors. We do not have prospective data to guide our sequencing decisions. We've got great retrospective real-world data that is emerging that is suggesting whatever ADC number 2 is used tends not to perform as well as ADC number 1. There's also some interesting data about using this sandwich approach of putting in an agent like eribulin in between, or at least any chemotherapy that has potentially a non-cross-resistant mechanism of action, and then coming in with the alternate ADC. But I would put in a plug that we need just more ADCs with other targets and other payloads.
Exactly. So let me ask you, assume these drugs are both approved, and that's probably a safe bet. When you're talking to patients, let's start with side effects, because we're in this era of shared decision making. When you explain the potential side effects of to patients about each of these drugs, how do you tell them, you're going to deal with potential side effects or hopefully mitigate them entirely?
So I think I would start out with saying that the kind of care that we deliver in really comprehensive quality cancer care is a team effort. So obviously you have the oncologist as part of the team, but we really rely heavily on our nursing support and our APPs and PAs that may be in clinic with us and our pharmacists that are assisting here. And increasingly we need other subspecialists to help us out as well. So I think when we talk about toxicity, we really need to educate our patients. We need to make sure our nurses are also educated with these new therapies and understanding how to do their chemotherapy teaching to set expectation for our patients. When we have prophylactic strategies to prevent adverse events and side effects, I think we need to really lean in and make sure our patients are aware, informed, have access to those agents, and are using them appropriately. So for example, with Dato-DXd in the TROPION-Breast02 study, we really saw that using frequent oral steroid rinses could mitigate and help prevent the stomatitis. Cryotherapy during infusion time can be helpful, ice pops, ice chips, that sort of thing. With the ocular surface tox, I think as we've engaged with more ophthalmologists and brought in optometrists as well to help us out here, we're seeing that the mechanism of action of that surface toxicity, the keratitis or dry eye, is not the same as I think what oncologists have seen with other antibody drug conjugates causing eye toxicity in other disease states. So I think for breast oncology, this is going to be something new we need to learn. But our ophthalmologists have a lot of experience in the space with other ADCs that actually cause more trouble. So again, using those steroid eye drops can be helpful, lubricating eye drops. I've even had patients doing some sort of cold compresses to the eye, minimizing use of contact lenses can all really help. Fortunately, we're not seeing adverse events that can be particularly dangerous, like interstitial lung disease, for example.
Good. So just to come back to the ocular stuff, because I think, people might have some pause when they hear that litany of things, but you might want to emphasize, or, just even though we have these maneuvers, this is not a huge day-to-day problem.
That's right. Those events were primarily grade 1, grade 2, and they were looking for them on the trial, which is very different than in standard practice.
Right.
So fortunately, the label indication for Dato-DXd, which we've had even in hormone receptor positive disease, just recommends that baseline exam, and then essentially it's as needed, right? If your patient has issues, which is not likely to happen, and then annually thereafter. And that's a wonderful thing to think about annually, that your patient may actually be on therapy for beyond a year.
Exactly. So I want to thank you, Tiffany, for taking us through both the ASCENT trial and the TROPION trial, 2 new drugs that we anticipate will be available for this indication for patients with triple-negative disease. And I want to thank everyone for listening. San Antonio is coming to an end, but we have a lot of data to digest, and this is all good for our patients. Thank you.
Thank you so much, Bill.